So I'm Jodi Kashmere. I'm a neurologist in Edmonton. I work in the community. So I see lots of people with Parkinson's disease, but I do see lots of people with other neurologic conditions as well. And so I've done this topic a few times live back in the good old days before COVID, and virtually once in Edmonton. And so Emma asked me to do this question and answer session. So this is for you. This is your questions. I am here to answer whatever I can. And I'm just going to start by answering the questions that have been provided to me in advance, just so we make sure we cover all of those things. And then I will just open up the floor to whatever you'd like to talk about. So just to get a little start, it's important to remember that young onset Parkinson's disease is a bit unique compared to typical Parkinson's disease. The average onset is in the mid-60s, so people with onset in their 40s, 50s, or younger have a little bit different issues sometimes. So the course is often slower, and people often do work for 10 or 20 years with Parkinson's disease. There tend to be more dyskinesias, fluctuations, dystonia, depression, and restless legs, all of which are manageable and all of which we can talk about. And the good news is that there are less problems with balance and less cognitive decline that occurs. Young onset Parkinson's disease is probably more likely to be genetic. It's not always genetic, but there is a higher chance of having a genetic mutation. And right now there is probably about 25 genetic mutations associated with Parkinson's disease, but that will change because there's so much research on genetics. And hopefully if we can determine more genetic causes, then we'll be able to find cures for that as well. So these are the questions that I was given in advance. So I'm just going to, I just broke them into some categories. So I'm just going to start and work through these. So a question about how to manage night terrors. Now, I just want to clarify a little terminology, and it's a bit of semantics, but it's somewhat important. Night terrors is a condition where people are very fearful during the night, and it's kind of like a really bad dream, and you wake up very frightened. This can occur in anybody, and it's not at all related to Parkinson's disease. It's actually more common in kids, more common when you first wake up during the night, and it is worse with fever, with stress, with sleep deprivation. So it's not specifically with Parkinson's disease. Versus REM behavior disorder, which is very specific to Parkinson's disease. It can actually be a precursor, so people can have REM behavior disorder for years before they even get Parkinson's disease, and probably a third of people with Parkinson's disease have REM behavior disorder. It's caused by the same pathology, which is alpha-synuclein, which is a protein which accumulates in the brain. What it is a sleep disorder that occurs during REM sleep, and REM sleep is the time that we dream. And normally when you're dreaming, you should have dream paralysis so you don't move your body. But in this condition, the sleep cycle is not working properly, so you actually live your dreams. So people are thrashing and kicking and punching their wives and falling out of bed, and it can be very dangerous, and it's really disabling for the bed partner. Usually it's during sleep, so the person who's doing it isn't even aware of it unless they wake up with an injury, but their spouses can be definitely injured during the night. So it's a very important thing for spouses to be aware of. There are treatments for it. The common medications used is melatonin, which you can get at the health food store, starting with 3 milligrams and increasing to a maximum 10 milligrams. Or clonazepam, which is a prescription medication that you would need to get from your physician. But both of those medications work quite good at treating this. If you don't want to take medication, the option is to have a really big bed, or to have your partner sleep in a different room or a separate bed. Or sometimes people will even need to move their nightstands or move their lamps just so that they don't injure themselves during the night. The second question was about dystonia and cramping. And again, these are two slightly different terms, so I'm going to talk about both of them separately. Dystonia is a fixed muscle contraction. So say the hand going like this, or in Parkinson's disease, it's often the foot that turns in. It's a muscle that just goes into basically a spasm or contraction and stays in that position. It's often an off symptom in Parkinson's disease. So it happens when your medication's not working. And it can be treated by adjusting some of the medications on the off stage. Can also be treated with other medications that are muscle relaxants. The ones that we would use are prescriptions, baclofen, Valium, Artane, Cogentin. So there's a bunch of different medications that can be used for that. And Botox is also used for that. Botox injected into the muscle, so it weakens it just slightly so it doesn't go into that fixed contraction. Botox does not cause muscle loss. It doesn't cause you to become prolonged weak over time. And there's not really a lot of complications to using Botox other than the pain of the injection. Botox wears off after 3 to 6 months, so it does have to be repeated injection. And sometimes it needs to be fine-tuned to get exactly the right dose and the right muscle group. Cramping, on the other hand, is a brief muscle contraction that usually lasts seconds. It feels like it's going on forever, but it's typically less than 1 minute. And cramping is really common. 50% of adults over the age of 50 have muscle cramping. I went to a course on muscle cramping at Mayo Clinic one year because I see so many people with every condition that have cramping. And I wanted to know how to help these people because it's a really tough problem. It's very painful. And the result I got out of that was nothing works. But I still always tell people to try tonic water if you haven't tried that before, because there is some evidence that tonic water can help. Try to get the low sugar one though, because tonic water actually has a lot of calories. It's not really that healthy for you. Magnesium supplements sometimes help people. Vitamins D, E, B, it's all worth a try. And there are some prescription medications as well. I've never found them to work very well, but sometimes we'll try gabapentin or Dilantin, which is actually an anti-seizure medication. But it's a tough problem to treat. You're better off if you can use heat, massage, stretching, rather than using any medication for it. Temperature regulation is something that I did not learn about when I learned about Parkinson's disease. And I started to see patients and they would come in and complain to me about sweating. And I would say, well, that's not part of Parkinson's disease. That's your other problem. That's your hormones or something else. And they taught me that I was wrong. Temperature regulation can be a problem in some people with Parkinson's disease. It might not be common, or people might not talk to me about it, but there can be changes in sweating patterns and people can get a lot more sweaty with Parkinson's disease. This can also be an off symptom. So adjusting your Parkinson's medications to have less off time can sometimes help that. The other thing is really just lifestyle, keeping a cool room, sipping cold water, having a cooling vest or a cooling scarf, easy breathing natural fabrics, changing your shoes and socks frequently. There's not really good medications that work for temperature regulation other than adjusting your dopamine medications. Swallowing is also a problem that can occur in Parkinson's disease, but not necessarily so. And if people are having swallowing problems, I always recommend a swallowing assessment. And in Edmonton, we send people to the Glenrose Hospital where they do it, but every town or every center has their own place that does it. And then the speech therapist will actually test different consistencies of swallowing, like bread or crackers or pills or water, and make some suggestions on how to swallow safely. Generally, they will say, always be fully upright when you eat slowly, cut your food into small pieces, take a few swallows. So if you have trouble initiating swallowing, take a swallow, chew again, swallow again, and just have multiple swallows for each bite of food that you're taking. Make sure that you stay upright for about half an hour after you eat. And then if there's certain consistencies that are a problem, typically people have problems with thin liquids like water, then you can get thickeners. Some people like that, some people don't, but it can make it a little bit easier to swallow it. But really the speech language pathologists are the ones that usually help address some tips on managing swallowing problems. Does anybody have any questions on these particular things, or did I address the questions that were asked?
I just wanted to ask a question.
Sure.
Is Botox for dystonia normally covered by Alberta Health Services or by insurance?
Yes.
Okay.
Botox for neurologic conditions, fortunately, is covered by insurance always.
Perfect. We have another question, but it's not related to these topics here. So I'll give it a minute just to see if there's anything else on this, and then we'll move along.
So here's the big topic. And sorry for the slide, but I figured it was better just to have everything on one slide so you could see all the options at once. This is medications for Parkinson's disease. And this is the question that people ask me the most about. So I thought I'd just kind of put it all together in one, and then we can always come back and address anything specific about these medications. So I'll just work through them a little bit, starting with the levodopa. Levodopa is the bread and butter. It's the hallmark medication. It works the best. There's nothing that compares to levodopa. In Canada, we have basically two formulations of Sinemet and Prolopa. They are just made by different companies. They have different enzymes attached to the levodopa. And so the purpose of the enzyme is to actually get the dopamine into the brain so that it's not just digested through your guts. And so they work the same way, but they just have different enzymes. So some people like one and some people like the other. Prolopa is a capsule, and Sinemet is a little yellow tablet. I'm sure everybody has probably seen Sinemet. Sinemet in Canada comes in a long-acting formulation, which is not a good long-acting formulation. It's very erratically absorbed. So sometimes people have a lot of off symptoms, or sometimes it doesn't kick in, sometimes it doesn't work. You never know when it's actually going to start working. There are other formulations of levodopa available, especially in the US. They have quite a lot of different preparations of levodopa. We do not have those in Canada. That's something a lot of my patients will read about online, especially if you're reading like Michael J. Fox or something like that, where they have American-based. We don't have any of those preparations that are approved in Canada. The second big category of drugs is dopamine agonists, and these medications work by stimulating your own dopamine receptors. So pramipexole and ropinirole have both been around for a long time. Rotigotine is slightly newer. It comes in a patch formulation with different strengths, and it's a patch you wear for 24 hours. And then the newest one in Canada is apomorphine, and it's a really bad name because it has nothing whatsoever to do with morphine. It doesn't treat pain. It's not addictive. It just shouldn't have been called that in the first place. And it comes in two formulations, Movapro, which is an injection pen that you give yourself, and Kinmobi, which is a little sublingual film. I probably have one in my desk if you've never seen one. I'll open it and show you what it looks like. It looks like this. It's a little tiny, like a breath mint or a breath paper that they used to make. You put it under your tongue. So that's the way that one works. When you have dopamine in your body, there's two enzymes that break it down. One is called COMT and one is called MAO. And so what these medications do is block those enzymes so that the dopamine stays in your body longer. So I always refer to them as a levodopa booster because they just keep the dopamine in your system for longer. And amantadine is a medication that was designed many, many years ago as an antiviral medication. It doesn't work for that. Coincidentally was found to help fatigue in people with MS and dyskinesias in people with Parkinson's disease. So nowadays for Parkinson's disease, we mainly use it to treat dyskinesias. It was used as kind of a starter medication back in the day, but it's not very commonly used anymore because we have better options. Young people with Parkinson's disease and bad tremors may see these medications. They are associated with a lot of side effects and not very well tolerated in older people. So really, I have a couple of young people that do really well on these medications, but we try not to use them in older patients just because of all the side effects that occur with them. And then Stalevo is, I just threw in the bottom just because people might recognize that name. And it's just a combination medication. It's combining the Sinemet and the entacapone into one tablet. Does anybody, I'm going to talk about off periods next, but before I go on, does anybody want to talk about anything else about these medications?
We've got a question here. Someone wants to get involved with research related to Sinemet and why protein causes the medication to be less effective, but they're not sure where to begin. Do you know of any research that's ongoing in Alberta that's related to Sinemet and protein?
I don't. I have a patient who's going to UBC to do a study on probiotics, which is kind of related with gut and Parkinson's disease, but I don't know of anything going on in Alberta, but I might not know everything that's going on in Calgary. So there could be things in Calgary that I don't know about.
From my understanding, I don't think there's anything in Calgary for protein right now either.
If you're interested in clinical trials and you want to see what the options are out there, it's very American dominant, but if you go to Fox Trial Finder, he has a lot of information about trials. And then they also have a link to the NIH, National Institute of Health website, which actually lists all the Parkinson's trials that are going on. I looked earlier today and there's 3,200 trials going on with Parkinson's disease worldwide. And you can focus that down. So you could focus it down to protein or focus it down to Cinemet and see if there's any trials going on and see where they're occurring. Mostly they're usually not in Canada, they're usually in the US or Europe or sometimes in other countries. But it's just nice to know if such trials are going on. And occasionally there are people that have the financial abilities to travel and do trials as well. So those are the best websites, the NIH clinical trials and the Fox Trial Finder.
Perfect, thank you. I will send those out when I get the document from Tanysia, so you guys can take a look at those links if you want to. The other question was also related to protein and food.
Yes.
Did you want to do that one now?
Sure, that's a really important question.
Okay, someone's asking, how important is food? Can you suggest the best food to eat or the best diet to follow? They've read that it might be wise to avoid dairy products such as cheese and yogurt.
So the issue with protein and Parkinson's disease is related to one thing, and that is levodopa absorption. So when you take your levodopa with protein, it blocks the absorption of your medication and you don't get the full benefit of the medication. That applies only to levodopa and not to the other Parkinson medications. So if you're worried about getting the most bang for your buck from your levodopa, you should really take it half an hour before you eat or an hour after you eat. And that protein applies to all protein, which is vegetarian protein, tofu, beans, dairy protein, cheese, eggs, and meat. And so if you wanted to do the best job you could for your Parkinson's disease, you would try to time your medication around your meals. That being said, it's not always possible to do so, and you got to live life and you got to do things you enjoy. So, you do the best you can, but just keep that in mind, is that the protein will have an impact on the levodopa absorption. That's the only issue with protein in Parkinson's disease being harmful. Protein is critical for muscle mass. And what I find is sometimes as people get older and they naturally lose muscle, that they get weaker and more frail, all of us. So it's really, really, really important to get your protein. And so however you want to get it, meat or vegetarian sources, whatever, it's just important to get your protein around the times of your levodopa. And so I don't think you should be avoiding anything with protein. There's no studies that show that dairy harms Parkinson's disease. There's no good research studies that show that. There's a study that shows everything that exists in the world is bad for you and everything that exists is good for you. But if you're looking at really good clinical trials, there's nothing that says that you shouldn't have dairy with Parkinson's disease. The diet that is shown to be the most beneficial for all neurologic conditions, really, particularly with dementia, but with other things as well, is the Mediterranean diet, which is fish 3 times a week, lots of fruits and vegetables, whole grains, less meat than a typical Alberta diet, a tablespoon of olive oil a day, a handful of nuts a day, avocado is in that, and a glass of wine with meals is with dinner once a day, not every meal is in that diet as well. And there's also some new combination diets that combine that Mediterranean diet with the DASH diet. And the DASH diet is just a low salt diet, which was good for blood pressure and heart. So those are the diet studies that have been shown to be the most beneficial for your brain overall.
Okay, thanks.
Is there any way to find out which of those medication works the best, or this is just trials and errors?
Trial and error, yeah. And the one that works the best for, person A does not necessarily work the best for person B, because everybody's bodies are different, everybody's enzymes are different, everybody's tolerance to medications or side effects are different. So it's really always trial and error.
What is the cutoff for the dopamine agonist?
By cutoff,
age
cutoff?
Yeah, age cutoff.
There is not an age cutoff.
Well, you had said that there's you don't recommend it for older people. What would you call that?
I was talking about anticholinergics for older people. Yeah, for I have somebody in his 70s and I wanted him to try coming off of it, and he did. And he felt much worse off it. So he called me today and went back on it. So, you know, I don't think there is an age cutoff. That's just a general guideline. But, you know, some 70-year-olds are super well and tolerate medications really well. And some 50-year-olds are really unhealthy and just can't tolerate any medication. So it's no rule.
Okay, all right, thank you.
I had a patient in today who is 87, and he actually takes Mirapex. And that's not something I would always use in people in their 80s, but he's been on it for a long time. He's doing great. He feels really well on it, so he remains on it.
All right, we can move into the off periods of medication.
Okay, this is another big question, and this becomes kind of a hallmark of managing Parkinson's disease after the kind of early stages and the honeymoon and period where everything seems to work really well. Eventually, doesn't always work well. So these are some strategies to manage off time. And by off time, I mean any time when you feel like you're not getting the most benefit from your medication. So that is wearing off after you take your medication. It doesn't last as long as it used to. When you wake up in the morning and you're just off and you can't get going. Unpredictable offs that can occur any time of the day and aren't associated with the timing of medication. Or when you take your medication and it takes longer to kick in than it should. Normally with Sinemet, we always say it takes about 30 minutes to kick in and it lasts approximately 4 hours. Everybody's a little different and that changes over time, but that's just kind of a ballpark. So that's what I mean when I say off time. The best way you can figure out your off time is keep a calendar or keep a spreadsheet during the day of the times you're on and you're off and when your medication's working and when it's not working. That's extremely helpful for your neurologist to see how much off time you're having, which is important for clinical trials, but is also important in just adjusting your medications and getting you functioning the absolute best you can. I always start with lifestyle things before medication because I think that lifestyle is better. And if you can do that instead of taking medication, I think that's always ideal. So diet is one place where that comes in, making sure that you're taking your medication without food so that you're getting the best benefit from your medication. Making sure that you're getting regular sleep, that you're getting regular exercise, that you're keeping your body healthy. With the levodopa, the key is taking more frequent, smaller doses. So sometimes at the beginning of the disease, you take it twice a day, then you take it 3 times a day, then you take it every 4 hours, then you take it every 3 hours. So levodopa always works, but sometimes you need to take more and more as the disease becomes more severe. The other option is to add some of these other medications that I mentioned on the other slide, which is why I put them all on. They the ones that keep the action of levodopa lasting in your system longer so that they can decrease the off time. All of these medications are studied as a goal of decreasing off time. Duodopa is an intestinal infusion of levodopa. So basically you put in a stomach tube, you get a little pump like diabetics have an insulin pump. You keep it with you all the time. It constantly pumps in dopamine. It's a medication for people with more advanced Parkinson's disease, but it does have a great purpose of decreasing off time. And then surgical options also exist for people that are having a lot of off time. In general, what we're going to do is lifestyle. We're going to use more frequent, smaller doses of levodopa spread throughout the day, which is kind of a hassle because it's hard to take medication frequently, but that's the thing that really works the best if you can keep up with a good schedule or a good routine. And everybody's different, so you have to find the routine that's best for you. My patients ask me what they should do, and I want to be able to tell them, and I give them my opinion of what they should do, but you live with it every day. You're the one who wants to be able to do things with your grandkids or wants to be able to go for a run or do these different activities. So it's important to kind of keep a schedule for yourself that works for your particular lifestyle. And everybody's different. Some people sleep until noon and go dancing every night, and some people are up at 4 a.m. So the schedule is different for everybody. If that is not working by just adjusting the levodopa, then that's when these other medications can play a role. One of the newer medications, and I'm just going to go back, the one that I showed you, the sublingual film. This is a medication that is for a rescue medication, basically, both of these, but the sublingual film is a little bit easier to take. So if you have a predictable off time or you have a really bad off time, and you can use these medications, and what they do is they kick in faster. So 15 minutes sometimes a little bit longer, and then they last about an hour. So these are medications that are used to just basically treat short off times.
Are those medication creates more constipation on top of Parkinson itself?
Yeah, possibly. The only
That's
one
the
that
problem.
doesn't, sorry, go ahead.
And that's the problem.
Yes, it is a big problem. The only one that doesn't really cause constipation is the entacapone, because it occasionally causes diarrhea. Not very commonly, but sometimes people do get diarrhea from this medication. But Parkinson's disease causes constipation, and all of the medications cause constipation. The anticholinergic's the worst out of all of them, but the other ones can as well.
That's bad.
That's the problem with meds, is that sometimes you end up treating one problem for another. So you always have to balance the side effects. Any other questions about off time?
I've got one. Can you hear me?
Yes, I can.
Perfect. I'm just trying to think. I'm on dopamine, regular every day, every 4 hours approximately. If I've got something coming up that's going to require a lot of energy and a lot of mental work, if you will, is it a big deal to take a couple of extra pills of the dopamine? Is there any downside to that? You know, I just need it for a couple hours, basically,
Yeah.
right? So
If you're my patient, I would say no. I don't know what your neurologist says, so I don't want to contradict them, but I tell my patients to do that all the time. If they want to go out in the evening to a special dinner, or they're going to watch a hockey game or something at night, and they don't normally do these things at night, and they're worried about, you know, their medication wearing off or not having enough benefit, I always suggest they take an extra. Sometimes people can just even take half a tablet and it's enough, or one tablet. Or people who are going for a long golf day, sometimes they need to take an extra half a tablet or an extra tablet on the day they're golfing. So I think that's no problem. I think that's a good strategy.
We have some questions in the chat here. Someone's wondering if you're going to discuss gastroparesis and Parkinson's. They've had that for about 14 years, and they've read that it could be the first symptom of Parkinson's. You know if that's true?
I didn't have that on my list from before, but I'm happy to talk about that. Gastroparesis means that your stomach just doesn't contract, so you just don't digest well. So your stomach, you feel full really easily, you don't digest food or tablets, and it can be an early symptom of Parkinson's disease. It can occur years before the actual motor symptoms of Parkinson's disease. It's again, treated, I always say lifestyle first. So eat frequent small meals, you know, spread out your food during the day. Try to balance it with lots of liquids or high protein fluids like a Boost or Ensure protein shakes, those kind of things. There are some medications for gastroparesis. The one we most commonly use in Parkinson's disease is domperidone, which helps with digestion. It helps with nausea with Parkinson medication. So a lot of people take that for their nausea, especially if they have nausea when they first start medication. The medication to be cautious of is Maxaran, which people prescribe very frequently for nausea and gastroparesis in people who don't have Parkinson's disease. It can worsen Parkinson's disease because it's a dopamine blocker. So it's something that you would want to stay away from. Domperidone is the only one that's really safe for Parkinson's disease. But if you can manage it with lifestyle first, that's a better option.
Okay, thank you. There's another question here. They're wondering if you have any younger patients who are struggling to tolerate medication. Have you ever seen that before?
I do. I have some patients that I really think should be on medication and they just cannot take it. It causes dizziness or it causes nausea, or some people just don't want to take it and they would rather manage without medication. So certainly it can happen.
Okay, looks like that's
one option for people that have, I'm just going to go back. all of these medications cause nausea. Sometimes people with the patch find it less so, but it can also cause nausea and dizziness. So the side effects of all of this category of drugs is really all the same. The best tolerated medication really is levodopa. So in people who are struggling, I start with a really tiny dose of levodopa. Usually I start with half a tablet, but sometimes I would even start with trying to do a quarter tablet, which is just like a little fragment of your pill, taken once a day for a week with food, just kind of get used to it. Take it with domperidone as well, and then just build it up very, very slowly. Or some people who haven't tolerated Sinemet have switched to Prolopa, and Prolopa comes in it comes in a capsule, so you can't cut it, but it does come in a smaller dose of 50 / 12.5. And so some people that can't tolerate Sinemet have tolerated Prolopa. Those are the kind of the best hints I can give. And sometimes people just don't tolerate medication, and then we just kind of do nothing with medication for a couple of years and try again, and then it's better the second time around.
Okay, thanks. I guess if you're having questions about medication, it's good to book an appointment with your neurologist if you can and have that discussion with them, because like you said, it's a lot of trial and error.
Keep a diary, number one, so your neurologist can see when you're at your best and when you're at your worst, which will really help plan your medications. And if you can, write down your questions in advance. If your neurologist does email or that intra messaging systems, then you can send them in advance to address, or just come in with an organized list of questions, and then we can make sure that we cover everything that you wanted to cover in your appointment. Sometimes we have a different agenda of the things I want to cover and what the patient wants to cover. So make sure you come in with your agenda as well.
Good. Someone's asking, what are the long-term side effects of Sinemet? And do they come on more quicker when you take the medication earlier on with young onset Parkinson's?
The side effects of Sinemet are dyskinesias, and dyskinesias are kind of these restless, kind of fidgety movements. Maybe you've seen it, or if you've seen Michael J. Fox in an interview, he's got a lot of dyskinesias. Of course, he's had Parkinson's disease for probably 40 years now. They don't come on faster if you have young onset Parkinson's disease. They are directly related to the amount of medication you take. So it's not a reason not to start medication, but it is a reason to start medication at a low dose and just build it up slowly as necessary and not take too much medication. That dyskinesias occur in about 50% of people with Parkinson's disease. A lot of people don't even notice they have them, or it doesn't really bother them. They'd rather have their Parkinson's symptoms controlled, the tremor and stiffness and slowness. So it's something to be aware of, but it's not necessarily a reason not to take Sinemet. That's one thing. The second thing is there's more fluctuations that occur over time. So that's, again, part of the Parkinson's disease getting worse and being on medication for many years, that you do need to take more medication or more frequent medication. Nausea and dizziness are early side effects of levodopa that usually get better over time. And there are no long-term risks with the medication. So there's no, other than the dyskinesias and the wearing off and fluctuations, there's no dangerous long-term side effects. It doesn't affect your blood count, your kidney, your heart, your liver. It doesn't have any negative long-term repercussions. Even if you start it when you're 20, you can still take it for the next 80 years.
So the same with Stalevo?
Yes, same with Stalevo.
How about blood pressure, lower blood pressure and dizziness?
As a side effect of medication or as a part of Parkinson's disease?
As a Parkinson?
Yeah, so Parkinson's disease can lower blood pressure. So that's the reason why people should always know their blood pressures or take their blood pressures, especially standing blood pressure. So what happens oftentimes if you're in the doctor's office, you're laying on a bed and we check your blood pressure while you're laying down and your blood pressure's fine, but then you stand up, blood goes down based on gravity and you feel lightheaded and woozy and off balance and your blood pressure is dropping. That's the classic thing that happens in people with Parkinson's disease. So their blood pressure might be fine lying down, but then it's really low standing up, and that makes you dizzy and throws off your balance when you're walking. So that's a really functional impairment. So all of these medications can cause that as a side effect. So decreasing the medication can sometimes be helpful. If you're on a blood pressure medication, you might need to lower the dose or change the blood pressure medication, or maybe you don't need a blood pressure medication anymore. I often see people with Parkinson's disease that had high blood pressure, and then they've had Parkinson's disease for 10 years. And they no longer have high blood pressure, but their blood pressure medication never gets stopped. So if your blood pressure is not high anymore, you might not need your antihypertensive medication anymore. And then there are specific medications that are designed to just treat that drop in blood pressure that I mentioned that occurs when you stand up. They're all prescription medications. Florinaf or midodrine or mestinon are all medications that can be prescribed for you if it's a disabling symptom. Making sure that you're well hydrated is also really important, because if you're dehydrated, that can make it worse. And a lot of people with Parkinson's disease, I think, dehydrate themselves because they feel like it's sometimes difficult to get to the bathroom or get to the bathroom quick enough, or they have bladder problems, so they don't necessarily drink enough, and that contributes to the problem as well.
I have a question about the batch.
Yes.
Yeah, the batch will my after I put it, my blood pressure will go high.
Always high or just temporarily high?
No, always.
So it's not a common side effect. Usually the blood pressure goes low instead, but everybody's body is different. So if you're always getting hypertension with the patch, the option is antihypertensive medication or getting rid of the patch.
No, I like it.
I thought you might say that.
Yeah, I like it. I'm keep it. And also the 4 milligram is good.
Excellent.
Yeah.
I've had quite a few, well, not quite a few. I've had a few people recently have a really good experience with the patch.
I have a question in relation to the patch. Kind of similar to Botox. Is that covered by insurance or by Alberta Health Services? I heard from someone in Calgary it was, but then I heard from someone in Edmonton that they had to pay for it. There was no coverage.
Yeah, I also learned about this from a patient. I learned tons of things from my patients. I thought it was not covered, and I always thought that it's really expensive. So mostly I never prescribed this patch in Alberta. And I had a patient move from Saskatchewan where it was covered and moved here and told me that, he should be able to get it here. And so I agreed with him, of course. And so we contacted Blue Cross and we actually did get it covered for him. And then I started to realize that I could do that for every patient as long as I filled out the right form.
Okay.
So it is covered by Blue Cross, including Seniors Blue Cross, but it has to be filled out. You have to have a special Blue Cross form for it, justifying that you've got advanced Parkinson's disease, but there's no criteria for what advanced Parkinson's disease means. You just have to have a neurologist that says you have advanced Parkinson's disease, and you have to have tried other medications or been on other medications, which most people would have been. So I have had good experience with it being covered in the last year. And people with private drug plans from their work, it's always been covered pretty well.
Okay. Off the top of your head, do you know if there's any other medications that require a sign off from a neurologist?
Rasagiline, Azilect, is a expensive medication that is not covered and probably never will be covered. It is generic, but it's still expensive. The new apomorphine formulations are brand new medications, so they are not covered. I was told today that they're anticipating that Kinmobi is going to be covered by Blue Cross starting this fall.
Okay.
And so they don't know what the criteria will be yet, but it will probably be the same as the rotigotine patch, I would think, since they're medications in the same category. And just out of interest, I was also told today that this costs $10 each time you use it. So each time you use one of those little papers that I showed you, it's $10. So it's a very expensive medication. So I don't think it will really be used until it's covered.
Okay, thank you. Someone's asking if there's any natural foods or vitamins that can help with dystonia.
Not that I know of. I always tell people to try magnesium, and I always try people to try a B complex, try a vitamin D, vitamin E. Some people respond differently, but there's really no studies that any of those work for dystonia.
Okay, and we've got someone else in the comments just saying that they do take Azilect and it's covered. So that's good to know.
If you have a private plan, it's covered, but it's not covered by Blue Cross.
Okay.
Which is the same for, you know, for a lot of medications out there. Private plans that will generally cover more than the Blue Cross. And which has become an issue sometimes when people turn 65, when they go to Seniors Blue Cross from their other plans, and then Seniors Blue Cross doesn't cover it.
It's good to know.
Yeah, something to be aware of for your financial planning. And if you're going to be in that situation and you have the option to extend your medication plan from your work plan, it might be something that you might want to look at doing.
Good advice. Okay. Is there any other questions? Or was there anything else that you had on the slides?
Let me just see what yes, somebody asked me my 1 or 2 tips, and I can tell you my number 1 to 10 tip: exercise, 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 exercise. So the only thing that slows progression of Parkinson's disease is regular exercise. And I preach this a lot, but you know what? I see such a difference in my patients who exercise regularly. I mean, you might not notice it in 1 or 2 years, but you notice it in 10 and 15 years. So any kind of exercise that you enjoy, but find something that you love to do and keep it up. Dancing, boxing, water aerobics, some good physical activity that gets your heart rate up. Walking is really good and walking is really important, and everybody should walk all the time. But some people who are just going for a leisurely stroll, walking the dog stopping every 5 seconds to sniff something, are not getting the maximum benefit from the exercise. So you want something that's, you know, is a little bit hard for you, that you have to work a little bit hard at. Stationary bike, rowing machine, you know, anything you like to do, just find something you like to do, and please keep it up, because you will really notice a difference in the long term with strength, balance, mobility. These kind of things do not respond to medications, and you really need to exercise. And if you can slow progression of Parkinson's disease and take control of your disease, that's the ultimate goal. I am also a big proponent of lifestyle. As I mentioned, you know, eating healthy, looking after yourself, sleeping is really important as the time that the brain heals itself, doing things you enjoy, socializing, you know, not becoming withdrawn, which we've all done our fair share of during COVID. There's a lot of studies of COVID and loneliness in Parkinson's disease. It's been a really big problem. It's really important to maintain social contacts. And then finally, I would say take your medications regularly, because if you're taking them all over the place and erratically and you're missing some, your dopamine levels are going up and down and up and down, and it confuses your body and it confuses your brain, and it's probably not good for your brain. I mean, if you don't have Parkinson's disease, your brain's going to be making a constant amount of dopamine, and that's what you want. So ideally, when we're replacing medication, we want to have a nice even amount of dopamine all the time.
Someone is wondering, how many times a week should we be exercising?
Every day.
Very
Yeah, where are you gonna find the energy for all this?
Well, you know what? I think that exercise should be your number 1 job. I think before anything else of importance, I know you might have to look after little kids, that, you know, you might have to do that as a priority, but I think that exercise for 30 minutes a day is the most important thing that you can do. So I think that should be your number 1 job, and I think that should take priority over everything else.
Yeah.
I know it's not always easy, and it's kind of just flippant for me to say that, but it's so critical.
When I exercise, not to get enjoyment, I just exercise not to get injured, because I'm pulling my muscles. And
Yeah, I mean, it's nice to find something you enjoy, if you could find something, but if you can't find anything you enjoy, then just think of it as your number 1 job that you have to do to look after yourself.
Go swimming.
Yeah, swimming's great. People who have a lot of pain, sometimes with Parkinson's disease, you can get pain or back pain, and lots of people have joint pain for other problems. Exercising in the water kind of takes care of that, takes some of the pains away.
I put this comment in the chat, but I'll throw it out here as well. If you need help finding exercise that's local to your community or offered through our organization, you can always give us a call. Sometimes it's nice to do it in a group setting. Being with other people helps with that apathy and getting motivated to go, and you're holding each other accountable. And it's nice when you know people that you're exercising with.
A lot of my patients love the boxing program in Edmonton, and I'm sure there's, similar programs in Calgary and elsewhere. A lot of my patients love the Zoom exercise programs that are done through Grand Prairie, and the Zoom programs through the Parkinson's Alberta too. There's great exercise programs in person and on Zoom if you can't get into the actual class. They're hard classes. They are a good workout.
Yep. Don't tell me.
Okay, we have a couple more questions here. Does coffee affect MAO inhibitors?
Kind of. Coffee is really interesting for Parkinson's disease. I don't know if anybody follows the literature. It's up and down, but coffee intake is associated with a decreased risk of Parkinson's disease. And so there is some thought that caffeine actually is good for people with Parkinson's disease. But the MAO inhibitors, which is this category of drugs, have a lot of interactions, and they have a lot of interactions with medications. Cold medications like sinus medications, cough syrups, Sudafed, St. John's wort, some of the antidepressant medications, tramadol, Demerol, pain medication. So all of these ones, you have to be careful with your medication interactions. Always check with your doctor or your pharmacist. Your pharmacist can certainly help you with that. There is also a theoretical concern of them interfering with some foods, like foods with high processed, like MSG, that kind of thing, like processed meats and that kind of thing that have that, and caffeine. And the risk is that they can cause hypertension. And so that's the only thing that you have to watch out for caffeine with those medications, is just watch your blood pressure and make sure that your blood pressure isn't going high by taking caffeine with an MAO inhibitor. That was a long answer to your question, but I just wanted to address the whole caffeine gamut. Caffeine, it can also help with constipation. If you have a hot coffee in the morning, that often triggers the bowels. So that's another thing. That's another reason to take caffeine. But lots of things are bad for you, and caffeine doesn't seem to be one of those things if you have Parkinson's disease.
Good.
What about alcohol? I mean, it should not make you happier and give you endorphins and dopamine?
This is the bad.
I don't know about that. I don't know. It hasn't been studied in a research study. I can tell you that for sure. Maybe it's a new study we should do. There's no definite interaction with alcohol in any of these medications. Obviously, you want to use alcohol in moderation because it affects your balance and your memory and can cause dizziness and other things. So those are things that are already a problem with Parkinson's disease. So you want to be careful with it. But there's no specific interaction with any of these medications and alcohol.
Good question. Okay, the other one is transcranial direct current stimulation or magnetic brain stimulation effective for Parkinson's?
There are lots of studies with that, and it really might be. I think it's very promising in the future. I don't know anybody who's had it. I've never seen any patients with it. I've seen it at trials, conferences and that kind of thing where people are giving talks. So I don't know yet, but it's something that we'll definitely have to watch.
Is that available in Alberta?
It is as a research tool. I've had some patients get it for other reasons. They've tried it for migraine and for nerve problems and things. So it is available as a research tool, but I'm not aware of it being available through the public healthcare system or even through a private system.
Okay.
What about the other treatments like CRISP, gene editing, or GDNF?
Yeah, I think those are really exciting for the future because those are actually looking at a cure for Parkinson's disease rather than these medications, which are just managing the symptoms, but not treating the underlying disease. So GDNF is a growth factor that's being injected directly into the brain to see if they can stimulate the cells that make dopamine, stimulate your own dopamine cells to make dopamine. So that would be, you know, potential cure if we could get something like that working. The genetic things like CRISPR are looking at making a genetic modification. So if you have a specific genetic mutation, say you have the LRRK mutation that causes Parkinson's disease, if you can go in and shut off that LRRK gene or change that LRRK gene, then you can potentially cure the Parkinson's disease as well. Now that's a little ways into the future, but that's certainly where research is going. And the other thing, of course, that a lot of people will ask about would be stem cells. So there's ongoing trials. There's 4 big trials going on in the world. They've been doing trials in Japan since 2018. They always present all the preliminary data, but they've never presented any final data that I've seen yet. But that is also a potential treatment. Before, when they were using embryonic stem cells, it's a little bit harder to access embryonic stem cells, but now they use something called pluripotent stem cells, which they just grow from other cells in the lab. And so they're directly injecting those into the brain and to see if they can make dopamine cells.
Hopefully in our lifetime.
Yes. I think, you know, one thing about COVID is it's really accelerated some science research. Obviously, just everybody coming together to try to figure out what's causing, you know, the information about the virus and the vaccines and that kind of thing. But it's really advanced a lot of therapeutic techniques with the vaccine trials. So hopefully that will kind of transfer into other areas of medicine as well.
Yeah, if they can find the vaccine in 1 year for COVID, they might find something.
Exactly.
What is the best way to get involved in research? I know in Calgary we have, we call it CAPRI, it's the Calgary Parkinson Research Initiative. Is there something equivalent to that in Edmonton, or is it just going through your neurologist?
I don't know, to be honest. I tell people to call Parkinson's Alberta and find support workers, what's going on for research, or the Movement Disorder Clinic. The patients tell me about the research studies. So they're usually done, I work in the community as, Edmonton's a little different because most of us work in the community, not at one movement disorder clinic. At the Movement Disorder Clinic, there are research trials going on, but we don't necessarily know about them. The patients usually hear about it from Parkinson's Alberta, and then they get involved, and then they come back and tell me about it.
Okay.
So it is an area for communication, I would have to say, is that we should have, you know, some place where people in Alberta can just go and see what trials are going on, like Fox Trial Finder, but an Alberta version.
Definitely, yeah. We have a couple on our website when we know about the ongoing studies, so you can look on our website for those. But yeah, it would be nice if there was a big one. Someone's asking, doesn't See Open register for research? And I think you might be right. If you're registered on the Canadian Open Parkinson Network as someone with PD, they might let you know about research that you are eligible for.
Okay, good. Yeah, like I said, my patients always seem to find these trials and they come to me. Even trials in BC, I have a patient who's doing the probiotic study right now. So I guess you just have to do a little bit of homework. I wish it was easier for you, but usually if you contact the movement disorder clinics, they'll be able to tell you what exactly research they're doing there, if there's something specific you're interested in.
All right, thank you. We just have a couple minutes left, so I'll leave the chat and see if there's anything else, or if anybody wants to unmute themselves and ask. Now's your chance.
Quick question.
Yeah.
DBS, brainstem stimulation, is that covered through the Alberta government?
100%, absolutely, yeah.
What
In
makes people
Edmonton, we do
eligible?
about 1 case a month. I don't know how many you do in Calgary. I would guess it's probably a similar number.
Right. And what makes a person eligible for that?
Parkinson's disease that responds to levodopa is the #1 criteria. If you have Parkinson's disease and you don't respond to levodopa, you're not going to benefit from deep brain stimulator. So you have to have kind of typical onset Parkinson's disease with a really good response to levodopa, but get complications from it. Dyskinesias, wearing off, unpredictable offs. The medication is just not reliable anymore, and it's impairing your functioning. Generally, you have to have good cognition, not advanced dementia or not psychotic. They do a lot of neuropsychology testing before doing this surgery, because that is a risk with surgery. And there's not a specific age cutoff here, but generally under age 70, I would say. I mean, there might be some 70-year-olds who are really well that would benefit, but oftentimes they'll look at younger people.
Is this different that it's called TMS?
Yes, TMS is transcranial magnetic stimulation. That is not a surgical procedure. It's like using a magnet to stimulate. So that is not invasive. And that's one of the things that's a new research topic, which might be beneficial and less invasive. The deep brain stimulator, they actually have to drill into your head and put electrodes into your head and then run a wire down to a battery pack in your chest. So that surgery has, more inherent risk associated with it.
Is TMS available in Alberta?
I have never heard of it available in Alberta.
I will add too, if anyone else has questions about DBS or duodopa, we have invited the DBS nurse in Edmonton. I believe her name is Michelle. She came and spoke about DBS, and we've had the duodopa nurse in Calgary, Eric, who came and spoke. So those are recorded and available on our YouTube channel if you guys are interested in watching them.
Oh, that's a great resource. Because those people see everybody who's had DBS or duodopa, so they would know.
Yeah,
they
are the experts.
Everything about it.
Yeah. Okay, well, it's 8 o'clock here, so we'll wrap up. Thank you so much for joining us and taking the time to share your knowledge. We really appreciate it. It's not every day that we get to pick the brain of a very expert neurologist, so we really appreciate it.